Evening, Prof. Would you mind if we start with you introducing yourself and talking a bit about the various roles you've had in haematology?
Well, I'm Brenda Gibson. I'm a paediatric haematologist from Glasgow. I've been a paediatric haematologist for more than 30 years, and I think I've probably, at some time in my career, had every role in haematology, or at least every role in paediatric haematology. And my main interests now are paediatric leukemias and bone marrow transplantation.
So, who or what sparked your interest in haematology as a career in the first place?
Well, as in my day, one became a junior house officer and then a senior house officer. So my first year as a junior house officer was on the haematology ward in Aberdeen, where Stuart Douglas was the professor of haematology, in fact the professor of medicine, and there was other very active consultant haematologists. And I think I was mainly sparked by their enthusiasm, but also by patients with haematological disorders. You get a very good relationship with them, and I think my main attraction was the relationship that you developed with patients who were in hospital a long time and kept coming back for recurrent courses of treatment.
What do you consider to be the greatest moment or the greatest moments in your career so far?
Well, I think I've had a lot of good moments. I suppose I could divide those into what I've seen, or the changes that I've seen in outcomes for patients. When I started off as a paediatric haematologist, the survival rate for children with acute lymphoblastic leukemia was about 60%. So a lot relapsed. I now work in an era where the survival rate is 90%. Even for diseases like AML, which we think are very poor relations to ALL, the outcomes are much better than they were then. I have seen diseases in children, malignant diseases in children, where when I started we hardly treated because the outcomes were so poor, where we now treat very aggressively. I have seen huge changes in haemophilia. When I was a haemophilia director, when I started off in haemophilia, we had HIV, we then had hepatitis C. We're now living in an era of recombinant factors, and we're moving into an era of gene therapy. So I think I've seen huge progress and huge changes, and I think that's very privileged. But I think the thing that you get little highlights every day. You know, I walk through my unit and I not infrequently get emails from colleagues who are now doing late effects clinics with people in their 30s and 40s who send you nice emails to tell you how successful or great lives these people have grown up to have. And that's as good a highlight as anything else.
What part of working in haematology gives you the most satisfaction, do you think?
Well, without a doubt, for me, it's patient contact. And these are patients that if you think of a child with ALL, you see them intensively for 2-3 years, depending on how long their treatment are, and then you see them for a long time thereafter. And I think we're very lucky, you know, we move into these families' lives at what must be their worst hour. By and large, they welcome us in. And I think the experience, so I think we're very, very fortunate to have that as a work experience.
What do you think are the key advances in haematology that you've seen over the course of your career?
My time, I think perhaps the thing that we've seen made the most difference in ALL and acute lymphoblastic leukemia has been the introduction of minimal residual disease, our ability to identify children who are very good responders, who we know will do well. So I think we've learned a lot about the biology of leukemia. We've learned about the cytogenetics, we've learned how to measure response, and I think we've learned how to stratify treatment. Because it's not just enough in children to improve outcomes, it's also very important to do it with the minimal side effects. And we have learned how to tailor treatment, particularly in ALL. So I think that's been a major advancement that I've seen. I have seen huge advancements in transplant. We've gone from sibling transplants, where if you didn't have a matched brother or sister, you didn't have a transplant, to unrelated transplants, to cord transplants, to haploidentical transplants, and now we're living and entering the world of CAR T cells. CAR T cells hopefully will just not bring better cures for children with leukemia, but they'll do it with far less long-term toxicity. They'll do it with preservation of fertility and a lot of the other side effects that we see with standard transplantation. I've seen haemophilia treatment go from crude treatment, which brought with it the risks of blood-borne infection, to very sophisticated recombinant factors, to gene therapy. And I've also seen gene therapy come in, or start to come into a lot of other hematological disorders, some of the hemoglobinopathies.
Next question was about the most significant developments happening right now in haematology. I think that's CAR T cells?
I think it's CAR T cells in leukemia. Certainly it's CAR T cells in ALL. In some ways, there are other diseases that are more in need of CAR T cells with poorer outlooks. So they are looking like they are going to be a great success story in ALL. We have antibodies, we have other treatments in ALL. We desperately need CAR T cells in AML and in other diseases that are doing much less well with very significant relapse rates despite the most intensive of chemotherapy. And gene therapy is coming for the benign disorders. So one day your generation may see no transplants, just CAR T cells for malignant disease and gene therapy for benign disease.
Out of a job?
Not necessarily. Somebody still has to look after those patients.
What do you think are the biggest challenges currently facing haematology?
I've always thought that one of the attractions of haematology was that it was a specialty that combined both laboratory and clinical aspects. I've always thought that as hematologists, as a pediatric hematologist, you work very closely with pediatric oncologists looking after solid tumours, and I've always thought I was very lucky to be able to do a bone marrow and go and look at the marrow and make up my own mind or know what this was, where they were highly dependent on pathologists for diagnosis, radiologists for staging. I think I always thought it was easier, for us to diagnose and stage. So I would hate to see a complete split off of laboratory and clinical haematology.
What role do you think the BSH has played in the development of haematology?
I think it's played quite a big role. It played quite a big role in paediatric haematology. I'm old enough to remember when there wasn't a paediatric haematology forum. So there is a paediatric haematology forum within the British Society of Haematology, and it was my generation who set up that forum. And that was done because in the rest of Europe, as you know, there aren't paediatric hematologists, they're paediatric hemato-oncologists, so they'll look after leukemia, they'll look after solid tumours, but they won't work in the laboratory. We were very keen to maintain that laboratory aspect of paediatric hematology, so we set up the Paediatric Hematology Forum to try and bring paediatric hematology into the BSH. So for paediatric hematology, I think it's been very good, to have that. It's, but I think probably for a general hematologist or for most hematologists or adult hematologists, the guideline has the British Society Clinical Hematology Guidelines have probably been the most important thing that the BSH has done. I mean, they are recognised worldwide as standards of care. So I think that's probably the most important thing they've done, that the BSH has done.
Where do you believe haematology will be in 60 years' time?
Well, that's hard to know, isn't it? If you think where it's come in 60 years, if it's come from all children with acute lymphoblastic leukemia dying to 90% being cured and even more, survive.
What do you think in 5 years then?
Well, 5 years' time, I think, will tell us how successful CARs truly are, whether or not we can develop CARs for other diseases. I mean, they're really just best established in ALL or in lymphoma, and whether we can get them in. And it may be very challenging, to get them into AML or into other malignancies. I mean, the advantage of the ALL CAR is that it can be an autologous CAR, and you don't have to back it up with an allograft, because the whole point of it is to avoid the late effects of an allograft in a child. whether it will be possible to identify anti-targets for AML and for other diseases that are not on other hemopoietic cells or not on other tissues, I think we yet have to show. But it would be lovely to see, immune therapy replacing a lot of chemotherapy that we have.
What about 15 years' time?
Well, maybe you will be out of a job in 15 years' time. Maybe we'll have cured everything, I don't know. I think my generation have lived through very intensive chemotherapy that's a bit like domestos and gets everything, is aimed just to kill off any cell there, whether it's good or bad. The next generation will see targeted therapy, whether that targeted therapy comes in as a T cell or comes in as a small molecule. So I think the big changes that will come is we will understand more of the biology. Understanding more of the biology will allow stratification of risk. It will allow identification of targets, for therapy. And I think we'll see far more targeted therapy, and we will live in an era where, though we talk about AML and ALL, and we recognise they're heterogeneous disease, we will treat them as truly heterogeneous diseases, and they won't all be one disease. They will be many disease. That will enforce, particularly in children, greater international collaboration, because a lot of these targets, these drugs will be targeting molecules or fusion genes that are rare, and we will need international collaboration to get enough numbers and to know if these treatments really are successful or not.
What are the best bits of being a haematologist?
I think haematologists work in a haematology unit. They work with, not just with colleagues, but they work with very experienced nurses. Most of us are still lucky enough to work with laboratory, colleagues. So I think we work with pharmacists. So I think we work in a very multidisciplinary team. And I think that's a huge advantage. You learn a lot from every other discipline. And I think we tend to be very supportive of each other. And I think the other group that we work with are the patients, for, in our case, the children and their families. And that's undoubtedly the best bit.
What do you think the haematology workforce of the future will look like?
I think we have to recognise that, at one stage doctors did a lot of everything. There are now other disciplines that can do bits of it better, than we can. The BMSs in the laboratory are now very, very well trained, and there's many aspects of what was once a medical part in the laboratory can be done as well, if not better, than BMSs. I think that goes for many things. I think haematology is a specialty that lends itself to advanced nurse practitioners, to clinical nurse specialists that can take on some of the roles of doctors. We are seeing, prescribing in all these areas, and I think equally pharmacists are now extremely experienced, in that area, and we're going to see prescribing pharmacists. So there are lots of areas that once were our remit and our role, which will be taken over by other disciplines, and they may do them better, than us. And I think if that's the case, then that's how it has to be, because it has to be the best people doing the most appropriate job.
What's your biggest hopes for haematology over the next 60 years?
Oh, well, I think that has got to be that we move ALL from 90% survival to 100% survival, that we see the same success with AML that we've seen with ALL, and that for whatever disease these children have and these adults have, that we improve the survival whilst minimising the toxicity.
What advice would you give to someone who's starting a career in haematology?
I think they have to accept it's not a great life-work balance if you do it well. But if that's what they want to do, then I think they should follow what they want, and know that there will be, and I think we can say to them truthfully, there will be many compensations, you know, for that. That I think it is a great specialty. You can be almost anything in haematology. You can be, you know, a day-to-day clinician, and I don't mean that rudely, but you know, if that's what you want, if you want to be a very hands-on doctor, you can do that. You can have a career in the laboratory, you can have a career in academia. I think it's a specialty that lends itself to people going down almost any route they want.
Okay, thank you very much.